My name is Shelby Yee, and it is my pleasure to present on behalf of my co-authors at the University of Hawaii. Our article is entitled Hepatocellular Carcinoma in Pacific Islanders, a comparison of Pacific Island-born versus U.S.-born. For an overview of our methods, we utilized a prospectively collected database of 1,608 patients with HCC referred over a 30-year period to a surgical practice associated with the only liver transplant center and Center for Liver Disease in Hawaii. We identified 252 patients of Pacific Islander ethnicity and grouped these patients according to birthplace, either Pacific Island-born or U.S.-born. Patient data collected included patient demographics, medical history, laboratory data, tumor characteristics, treatment, and survival. We utilized univariate and multivariate logistic regression as well as Kaplan-Meier analysis. For our results, with regard to patient demographics, PI-born patients were younger at diagnosis, and while a male predominance existed in both groups, this was more prominent in the PI-born group. PI-born patients more frequently lived in an urban area, defined by the U.S. Census as a geographic area with a population greater than 50,000, and were significantly more likely to be uninsured or have government insurance compared to U.S.-born patients. With regard to risk factors, PI-born patients had a 14-fold higher prevalence of hepatitis B compared to U.S.-born patients. In contrast, the U.S.-born group had a nearly 4-fold higher prevalence of hepatitis C compared to PI-born. Furthermore, when examining all patients with hepatitis C, U.S.-born patients are 4 times as likely to have a history of high-risk social behaviors that included history of illicit drug use, incarceration, or having tattoos. Significantly more U.S.-born patients suffered from non-alcoholic steatohepatitis and non-alcoholic fatty liver disease, had concomitant or history of other non-HCC malignancy, and were more likely to have a history of smoking. In terms of presentation of disease, PI-born patients were more likely to present with cirrhosis. However, there were otherwise no differences between groups with regard to mean size of primary tumor, presence of multiple tumors, or presence of bilateral tumors. For diagnosis and treatment differences between groups, of 190 patients with screenable conditions, including cirrhosis and chronic viral hepatitis, fewer PI-born patients were diagnosed through screening, with only 18% of patients diagnosed on screening compared to 28% of U.S.-born patients. PI-born patients were found to be 3 times more likely to forego treatment. They were also significantly less likely to receive local regional therapy. However, there is no difference between groups in those receiving surgical intervention, either transplant or resection, and no differences in the rates of undergoing ablative therapy, chemotherapy, radiation, or palliative procedures between groups. For other outcomes examined, PI-born patients were found to have a significantly higher rate of loss to follow-up compared to U.S.-born patients, with 11% of PI-born patients lost to follow-up compared to 1% of U.S.-born patients. 1-year survival is found to be similar in both groups, but PI-born patients were found to have better long-term survival at 3 and 5 years. Predictors of mortality were assessed through Cox regression. The model was adjusted for age, sex, BMI, BCLC stage, child Pew score, HCC risk factors, history of smoking, and previous non-HCC malignancy. The results demonstrated that U.S.-born status was associated with higher mortality risk, and liver transplant was associated with lower mortality risk. In conclusion, for the key findings of our study, we found that hepatitis B remains the primary risk factor for disease in PI-born patients, whereas HCC in U.S.-born patients is more associated with risk factors adopted with a westernized lifestyle. PI-born patients are more likely to forego treatment and be lost to follow-up, reflecting possible barriers to accessing care or differences in the prevalence of health-related cultural beliefs and practices. Both groups are equally likely to receive the opportunity for curative surgical treatment, either liver resection or transplant, and the PI-born cohort demonstrated higher overall survival at 3 and 5 years compared to U.S.-born. Thank you.